Okay, so first of all, I would like to thank my producer, director, my agent, Sarah Hodge, for this invitation and for her technical expertise in making this particular movie be up for an Oscar. So we'll move ahead as fast as we can. We have time to get some slides in. So usually we have to have the disclosures. So here are all the disclosures. And then now, experience, as you can read these for yourselves. I think the most important one is the last one, learn every day, but especially from the experience of others. It's cheaper. So what Sarah has put together is tricks of the trade. So there's 3 of them set up. So this is the first one on the cochlear implant. Dr. John House will be doing one on stapedectomy, and then Dr. Daryl Brackman will be doing one on chronic ears. Basically, I look at things going from known to unknown. So as I tell the fellows, it's most important that they understand there's no hope in neurotology. Everything has to be done by looking at one particular item and going on to the next. So each landmark is there for you to use. And it helps you then create a 3-dimensional picture of what you're doing. Also, when you look at your surgery itself, you can see in the upper corner there to the left where the hands are holding the instruments. You know, that particular gentleman is holding that instrument as a pencil, which means his thumb and index finger are in the way. He really can't see what he's doing if he has to look down the instrument. When you're doing things that are off the side, like tumor work, etc., that's great. But when you get to deeper structures, your hands have to move in and you have to look down the instrument itself to see what you're doing. And hopefully that you'll sort of continue those techniques while you're working in the office, seeing patients by removing wax. This talk is going to talk about all sort of 3 devices, not one in particular, but they're all sort of mentioned. So there's no talk about using the Neurolex or the Oticon device. It's broken up into these sort of sections, patient positioning all the way down to closure. So patient positioning. So first, we're going to use the Felipe Santos Memorial Towel. Now, the purpose of that is to maintain the head at about a 45-degree angle. Since the round window and the placement of where you're going to place the electrode is more posterior and inferior, you need to have that access. If the head is flat, it's very difficult to look down that area. So our skin incisions, these are the incisions that I have used in the past. We've all used. Initially, Dr. William House felt that this incision should not cross the device. So as the devices got bigger and bigger, the incision got pushed further back and more lengthy. We have learned over time that those incisions can cross the front portion of the device, the electrode, without having any troubles. So now incisions are very variable, depends upon your particular, say, desires and what you're used to. The main thing, though, is you have to be certain that you have placement of the device so that you have the on-the-head processor. In the initial days when we had body processors, the device itself was very close to the ear. With on-the-head processors, you need to be further away. But you have to be careful that you don't go too far back, because if you go too far back, now the true on-the-head processor, the single device that does not hook on the ear but sits over the device, if you go too far back with your device, the on-the-head processor will be sitting way up high on the head and way far back. So that's something you need to think about in placement of your internal receiver. So it's mastoidectomy, the first phase of the actual surgical approach. Approach is going to be the same, whether it's a aerated or sclerotic mastoid. The main thing you want to be careful of is your sigmoid sinus, whether it's far forward, and the height of the jugular bulb, because the jugular bulb, as you know, can be as high as the round window itself. In doing the mastoidectomy, the approach is going to be the same, whether it's a pediatric or adult patient. The difference, though, for the pediatric patient, especially the young patient, sometimes the bone in the mastoid is more marrow-like, so you need to use a diamond burr, rough cut diamond burr, to sort of get rid of that bone rather than the cutter, because you need to control blood loss all the way from the incision all the way in. I do not like to saucerize the margins. There are people who do saucerize margins like a regular chronic ear procedure. I want to maintain the superior and posterior margins as overhangs. That helps to hold the electrode in position, and then also maintain as many spicules within the mastoid as possible. The only sort of smooth area that you have is the posterior canal wall, because that's the wall that you're going to be looking down. The approach of the mastoid is similar, even though you have the overhangs, as you go high towards the middle fossa plate and anterior towards the antrum. The spina Henle is your external landmark for where your antrum is. So when you make your incision initially, you need to be certain that you see the actual external ear canal and the spina Henle with the curve as you go along that adic-scutal area above. You thin the posterior canal wall so that you can look down it. Oftentimes, if you leave the posterior canal more like a hood as it extends too far posteriorly, it will prevent you from seeing the posterior placed round window niche. And that creates a lot of trouble for trying to be certain that you know where you're looking. So thin the lateral portion of the posterior canal wall so you can see down the wall through the facial recess. Facial recess itself, it's a landmark that if you look at it as shown by the arrow, will give you access through to the facial, through to the round window itself, the round window niche. We use facial nerve monitoring when we're doing the cochlear implant surgery. It's rare that the facial nerve can be out of position, but if you do have a child with a malformation, you need to be very careful that the vertical portion is where you think it is and not somewhere else. The facial recess has these landmarks. If you think about the facial recess, the incus, the eye in the drawing points directly to the facial recess. So you want to be certain that you're staying with the incus as you're doing the surgery. So I like using the incus as my landmark. The other way of doing it for others is they go down to the mastoid tip, find the vertical portion of the facial nerve down towards the mastoid tip, and then follow it backwards to follow the chorda tympani. I don't like that particular method because the facial nerve, once it leaves the mastoid genu, is then going to be in a place where you're not certain where it is, because if the jugular bulb is high, it can be pushing the facial nerve out laterally. So I feel that using the incus as your landmark and working with the mastoid genu is the most appropriate way to do a facial recess, because everything is stable in essence, anatomically. The important thing in doing the facial recess, though, is to maintain that narrow incus buttress. Since the chorda tympani, if you think about a drawing where you look at the external ear canal from above, going from laterally to medially, the chorda tympani is moving away from the facial nerve, so it crosses the incus as it moves to the malleus handle. So the closer you are to the incus, the wider your facial recess. The further you are from the incus, the more narrow your facial recess. It's important because many times if people have a wide incus buttress, they may enter into the external ear canal, and then you get the possibility of a canal cholesteatoma and a cholesteatoma extending into your electrode. So you look at the stapes itself, the anatomy, then allows you to then look more inferiorly. As I said, the incus itself is the landmark, but the stapes is the landmark for the chorda tympani. So once the stapes is identified, try to drill more posteriorly across the facial nerve rather than anteriorly to widen the facial recess. When you go anteriorly, you run the problem of going through the annulus and having the canal cholesteatoma. You want to be, depending upon the electrode, you need to widen the bottom portion, the inferior portion, again, by hugging the facial nerve. And that's then where you work anteriorly and medially to the actual vertical portion, very carefully along the pyramidal process. You don't want to go too deep. You don't want to get into the stapedius muscle because then you may create some bleeding. but that gives you access to the round window niche for then your approach to look at the round window membrane. This is the extension. And when you're extending it inferiorly, sometimes the chorda coming back to the facial nerve, if the facial nerve is then being moved laterally by a high jugular bulb, it'll be pinched off. And so you need to use a smaller burr to actually remove that final bit of bone so you can see from the inferior aspect of the round window niche. When you think about drilling, realize that the shaft of the burr is what you're trying to keep from damaging the facial nerve. As you're moving in and out, working on the round window niche, it's important that you do not keep the drill running as you're moving in and out. But you also then want to be careful that you look at the shaft, and to be able to drill, you want if you're right-handed for this particular ear, right ear, you want the shaft to come in from below upwards, from inferior to superior, so that you can be looking at what you're trying to drill. If you don't do that and you're trying to just drill straight ahead, then you're blind in your actual approach. In those unusual patients where there may be some, say, difference in anatomy, then if you cut the incus tapedial joint, you can remove the incus itself, take down the bridge, and then you get a much more wide open view of the middle ear, the round window niche and membrane. So we've done that approach. Now we're going to look at our reset bed and periosseal pockets. So in doing the seat, I use the seat still for my adult patients. I'm trying to lessen the height of the device. As the devices become thinner, you may not need to do this, as much of a seat as we do now. The other purpose of doing the seat, at least for the adult patients, is to help maintain the placement of the device. So it helps prevent forward motion, anterior displacement of the device. For the pediatric patient, no actual seat is created, but my periosseal flap is done in such a way as I will use it as a tie down across the nose of the internal receiver to help maintain it in good position. In creating then a tunnel or a trough from the mastoid back, that helps to protect the electrode as it leaves the internal receiver. That's where most of the damage comes to these devices, is that where the electrode is leaving the internal receiver package. Now this slide actually is a little out of date now, recently. So in the old days, Medel would have electrode that came off the side of the device. So AB and Cochlear would come straight ahead, as noted in the drawing. Medel has changed, so their internal receiver package is just like AB and Cochlear. So for those of you that have done implants for a while, you pretty soon will see everybody has a common device. So we're pretty soon we'll have everybody having single head processors. The device, internal device, will see the same. As one device gets skinnier, the other devices will get skinnier. Soon they'll all be the same. In creating the pocket, the freer elevator works the best. So for kids, I place, as noted, the pocket medial to the pericranium and lateral to the temple bone. So it's beneath the pericranium. With the newer magnets that allow MRI scanning, the thickness between the internal receiver magnet and the external transmitter magnet have to be thinner. It's a little bit more, say, tricky. So for adults, my pocket is created lateral to the temporalis fascia and muscle. And for the pediatric patient, it's created medial to the temporalis fascia, muscle, and pericranium. But the pocket itself is made the same with the freer elevator. It's just lateral for the fascia for adults and medial for the pediatric patient. The tie downs we don't use anymore. There are certainly some individuals who use some form of a tie down. Now they have, in the old days, they were using the titanium plates and screws. Nowadays, they have absorbable plates and screws. I think the whole purpose is to be certain that your actual device itself is somehow fixed, and how you plan to fix it is just, up to your own personal preferences. This slide is probably important for those younger members. So the device, all devices now have some kind of bending action between the antenna and magnet portion and then the internal receiver portion. There was always a big push to be smaller and smaller and smaller. You pound your chest and say, I can do this in only a 1/2-inch incision, or I can do this in a 1/4-inch incision. You don't want to bend the magnet though. You can see that the antenna coil is wider than the actual internal receiver. So some people have tried to bend the antenna and magnet portion to get into a smaller opening. And if you do that, you can pop or weaken this elastic that holds the magnet in place. And so then the magnet pops out. So do not bend the antenna in any way to try to make it into a smaller opening. So now looking at the actual scala tympani and getting direction, there's 3 approaches, either a straight round window approach, the extended round window approach, or a cochleostomy. The drawing on the right-hand side appears to suggest the scala vestibuli and scala tympani are the same size. And yes, in this particular area they are, but if you're looking surgery to do a scala vestibuli opening, it's a lot smaller where we approach it than the scala tympani. So visually, you'll need to be aware of that when you're looking for a scala vestibuli approach. And so the cochleostomy is a separate end opening. And the way this is drawn here on the right-hand slide, it suggests you're approaching it from below. And that usually what happens in the old days, one of the physicians who taught how to do surgery approached it sort of from above. So he was passing through the scala vestibuli, the scala media, as he then got to the scala tympani. So it's probably best that cochleostomies are rarely done, and most individuals are going to be using either a round window approach or a extended round window approach. We're stuck. There we go. Okay, so for your different electrodes, let's go back one. Yep, okay. There are different electrodes that are out there. So this is just an example of one from AB. It's a mid-scala. They also make the Slim J. So the mid-scala is more of a perimodiolar compared to the Slim J, which is the lateral wall. Then Cochlear has their device with the wire electrode. There is then the Slim Straight electrode. They have their 632 electrode. Medel has multiple electrodes. The whole idea for these different companies, not to say one is better than the other, but there's sort of 2 main type of electrodes. So there's the lateral wall, sort of, as they call it, slim electrode. And then there's more of the electrode that's going to be perimodiolar or mid-scala. All of those perimodiolar mid-scalas have to have some kind of device that holds the electrode in position. So when you're using that kind of electrode, you're going to need more of the extended round window approach. If you're using the Slim Straight electrode, then you're going to be using just a straight round window approach. In these procedures, the whole idea though is to remove the actual bony niche so that you can see the round window membrane itself all 360 degrees. And then you're going to be looking at your electrode insertion so that you're going towards the nose. You first want to take your electrode, get it down inside, get it ready so that when you then remove the niche, your electrodes are ready to go. So you can sort of, if you're a right-handed surgeon, hold the electrode in your left hand, take your obtuse needle, create the hole in your round window membrane. And then after you've created the hole, your left hand is ready to go to advance the electrode slowly into the scala tympani. The purpose of that either the claw here or other instruments, or even the 22 needle suction tip, is to maintain placement of the electrode. So the force moving forward to place the electrode into the scala tympani keeps moving forward. The very flexible electrodes, the slim straight, or the Medal electrodes, very flexible electrodes, they have a tendency, as you're trying to move forward, they buckle inferiorly. And so the electrode can be supported by the 22 needle suction tip or other instruments. I like the 22 needle suction tip because it's not pointed. There's nothing that's going to allow it to sort of break. Or you could use these little claws in such a way to support the electrode as you're moving forward. If you go slowly and gently, the whole idea is to keep the electrode within the scala tympani. And that's what these slides show. With the perimedullary electrodes, you have a tendency to perhaps move out of the electrode, or for other things to occur like this. They can get buckling, they can get more rollover. So you just have to be careful as you advance that you're doing so slowly and carefully. That probably most individuals, if you're working with residents, they will use the 622 or the slim J electrode or the Medal, the 632 or the high focus mid scala for AB. Those are a little bit more difficult to place and more trouble can occur. So the main thing is to understand what electrode you have and the sort of nuances of each of the electrodes, because they all have problems. After the electrode is inserted, you can then take some soft tissue and support the area. Since if you have a round window approach, it's just a hole. So don't try to shove stuff through that hole, because then that's the whole idea of, doing soft surgeries to maintain the so-called fluid dynamics, I suppose. Don't push on the area to try to pack things in. If you've done an extended round window, you do have to put more tissue around it than a round window approach. And if you made a huge cochleostomy like we used to do in the old days, then there more packing is required. When you look at the electrode after you finish, though, then you're winding it, the rest of it, within the mastoid cavity. And then when you look at how you approach things, it's trying to maintain position and its orientation. So do so very carefully and slowly. With fixation, there's multiple ways of fixing it. The Tom Balcony sort of hook, Dr. Gantz with his tie down across the middle fossa area bone, or just trying to make the electrode stay within the mastoid by having overhangs. If you're going to be doing real saucerization of the mastoid and you're going to be following from inferiorly to superiorly from the mastoid tip up to follow the facial nerve, you're not going to have a whole lot of bony overhangs to maintain your electrodes. So you need to be careful with the slim electrodes. They're going to have more of a tendency to back out of the ear than the perimedullary or the old contour electrode, which is sort of holding themselves in. So I think you need to have some form of fixation, especially of these slim straight electrodes. Whatever you do, you just need to make sure it maintains its position. As far as closure, I use a 3-layer closure, no matter what the incision is. You want to be deep closure to, as I said, take my wide anteriorly based periosteal flap across the nose of the internal receiver device to hold it in place to prevent the forward migration. Then a second closure of the deep tissues is to take the pressure off the actual incision, and then a monocryl on top. I'm trying to reduce the chance that I'd have a so-called stitch abscess, spitting of the stitch, because just a little bit of infection that might be okay for a chronic ear is not okay when you have a cochlear implant. And then people just put steri strips or glue, I suppose, for the skin, whatever you feel is best for your particular method of closure. So in summary, when you look at the actual approach as a transmastoid facial recess approach, there have been other approaches set up, but as noted, not every new approach is really better than the older technique. No matter what you do, always think about the anatomy when you do this, going from known to unknown.
I do have one question. Can you talk about cochlear implants briefly in a canal wall down cavity and how you manage that?
Okay, so Sarah's question concerns canal wall down cavity. So the first thing that implies that there's been some form of, say, absence of any kind of covering. So you're going to have skin within the cavity. So the two issues are, one, making sure you get rid of all of the skin that's in the cavity. And second, making sure that your device electrode does not extrude. So other people have tried to elevate the soft tissue between the bone and the skin, assuming there's a certain thickness, and place the electrode beneath that soft tissue going directly into the cochlea. That creates two problems. One, I'm not certain that you really are able to make sure there's no skin that comes down close to where the electrode is. And more importantly, it's difficult to have the electrode lead not want to extrude through the skin. The body always wants to have the material sort of be separated from it. So for any patient who has a previous cavity, chronic ear, fenestration, prior fenestration, I will take everything out that I can, close the ear, so oversew the external ear canal, wait 3 to 4 months, then go back in and place the implant. At my first surgery, I will take a piece of elastic and put it into the middle ear space, so it sort of protects scar tissue from closing over the round window area. And when I go back and I work inferiorly to superiorly. So I go below and work my way up. Since I don't really need to find the stapes, I don't need to find the horizontal portion of the facial nerve. I could just leave those structures alone. So I'm going down inferiorly to the hypotympanum and then working upwards to the round window niche and then placement of the electrode. So I would rather have the 2 surgeries than create an attempt at 1 surgery where I go in and put my electrode in and then it breaks through 6 months or 1 year later. So then I have to have a second surgery to remove it. And then I got to wait and go back for a 3rd surgery. So I've done 3 surgeries and I burned 2 devices when I just have 2 surgeries and only 1 device. So for me, I'd rather be more cautious than to try to do everything in the first surgery.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.